hospitalized COVID-19 patients are not uncommon. With this background, we did a study titled Sight-Threatening Intraocular Infection in COVID-19 Patients in India. It was conducted in L.V. Prasad Eye Institute, Hyderabad and Vijayawada between April 2020 to January 2021. Laboratory confirmed cases of COVID-19 who presented to us for endophthalmitis management was included in this study. Data included complete demography, systemic comorbidities, detail of COVID care, their biochemistry as well as microbiology. A comprehensive eye examination was done for each patient. Endophthalmitis was managed as per institute protocol. We included 33 eyes of 24 patients. Cases of endogenous endophthalmitis coincided well with the COVID wave in both the states. Majority had systemic comorbidities. Mean interval of COVID-19 systemic symptoms to ophthalmic symptom was 15 days. Majority had anemia, thrombocytopenia, neutrophilia and lymphopenia and raised inflammatory biomarkers. All had received broad spectrum antibiotic and majority had received systemic corticosteroid. Out of 19, 14 had microbiologically positive vitreous sample, of which 11 were fungi, 2 bacteria and 1 virus. 11 of 21 had some systemic focus of infection such as candidemia, bacteremia, aspergillus, mucormycosis, etc. Ocular treatment included vitreous biopsy, vitrectomy, intraocular antibiotic antifungal, and when retina detachment was detected, silicone oil injection was done. 5 patients expired due to COVID-19 related complications. At the last follow-up, only 40% had visual acuity better than 2400. This is a 58-year gentleman who presented to us with pre-retinal exudate, and the species was identified to be Candida tropicalis. This is another gentleman, 59-year, who presented with retina detachment and choroidal thickening. The species was identified to be Fusarium equisete. 65-year gentleman, he presented with bilateral vitreous abscess and the microscopy revealed sefted fungal filaments, and the species was identified to be Aspergillus flavus. So, endophthalmitis is a rare but not uncommon occurrence in patients with COVID-19. It is associated with high mortality and blindness. Ocular infection is related with comorbidities, hospitalization, ICU admission. Fungus is the commonest organism. Thank you.
What was the total number of eyes and how many were culture positive?
So we included 33 eyes of 24 subjects, and out of 19 vitreous biopsy, 14 had some microbiological it was microbiologically positive either in smear or culture, out of which 11 were fungi, 2 were bacterial and 1 virus. And out of 21, 11 had some systemic focus of infection, 5 had candidemia, 3 had bacteremia, 1 had aspergillus in renal biopsy and paranasal sinus biopsy, and 1 had mucormycosis in paranasal sinuses.
So 5 patients did not undergo vitreous biopsy?
Yes, and 5 patients actually expired due to COVID-19 related complications. They were very fragile, unstable, and we could not do any surgical procedure for them.
Any intravitreal antibiotics were tried?
Yes, intraocular antibiotic was given in the OPD.
But that didn't work in most people?
No. Patient actually expired after a few days.
So most came with a situation that they needed surgery?
Yes. Early surgery is preferred in this type of cases, otherwise It progresses very fast, leading to vitreous abscesses, and those who presented very late, they after surgery also macular scar and dragging, pulling of retina that we found even with silicone oil injection.
Any more questions?
Only 40% had visual acuity better than 2400.
So what's your recommendation? So
So
now
we recommend routine eye examination for patients, particularly those who are admitted in ICU.
And all of these patients presented after discharge from an ICU.
12 weeks, within 12 weeks of discharge from the hospital.
But none of them were diagnosed during the ICU stay.
No.
None of them had undergone any eye examination during ICU stay.
No.
Is that okay?
I think that's very important because I also had, I think we had presented this case report in IGO where we have candida infection. He had multiple candida spots but no vitreous involvement and responded to intravitreal anti-fungal. But again, same story that he was admitted, underwent treatment almost for a month in the hospital and no eye examination. So I think that's a message we have to
We
take.
need to sensitize the physicians in intensivists about the need for ocular examination and documentation. So there your mobile fundus photography would be extremely useful. And second thing is, a lot of these were all fungal. So some like candida would be either related to the canalization or just a basic depressed immunity. Whereas the others like aspergillus and mucormycosis might often be related to reusage of the nasal cannulas, which are for oxygen or the high pressured oxygens, etc. So we need to sensitize the nurses and the staff that once you've used it on a patient, please chuck it, and they have to be sensitized about cleaning those tubings also, the source from where the oxygen comes in.
Yeah, we in our series we studied only 2 patients had level 3 and ICU care, and rest had received care in makeshift hospital or in level 1 or 2 ICU. So definitely ICU protocol is very important to prevent this type of fungal infection.
And they were the first wave or the second wave? Or
This is the first wave, so only one mucormycosis we saw that time.
So in second wave, did you get more?
Yes, and the varieties are actually different. So it presented one is very multiple retinochoroiditis at the periphery. There is the first presentation. Second is focal retinochoroiditis with localized vitritis. The third one is diffuse kind of vitritis and retinochoroiditis. And the fourth one is actually a very late stage phthisis and those who did not receive any kind of treatment.
Thank you.
Thank you.
Very
For-
good presentation.
Keep up the good work.